Thank you. So just to introduce myself, I'm Deep Shah. I'm a GP. I work in North Central London, and I led on the Lipid frameworks for the UCL partners proactive care frameworks. So can we go to the next slide? Now, the reason we worked and developed these frameworks initially, but because of COVID, we knew that the routine long-term conditions work had stopped for a lot of general practitioners, and we wanted to try and see how we can restart the work, but also make sure that we are risk stratifying the patients to make sure that the most appropriate patients who are high risk are seen by the most appropriate clinicians. So we developed these frameworks in conjunction with clinicians, GPs, and pharmacists. We made sure that there was public and patient insight into the frameworks, and we developed them with our local clinicians as well. So they're virtual when appropriate, but face-to-face when needed. And the big part of these frameworks are that we try and mobilize the wider workforce within the general practice team. So this includes clinicians, so pharmacists, healthcare assistants, but other clinical and non-clinical staff to help in managing these patients. And the other big thing we've tried to do is include a lot of support for self-management. A lot of these chronic conditions that we're discussing have a big self-management aspect, and the better we get at that, hopefully the better these conditions will be controlled in the long term. Next slide. So we have 6 frameworks. We have hypertension, asthma, COPD, lipids, AF, and diabetes as well. Today we're going to discuss the lipids framework, but we have all 6 available, and I'm very happy if you want some information on the other frameworks, then I'm very happy to discuss that this time or another time, and we can pop our email addresses in the chat so you can give some questions if you need on any of the other conditions as well. Specifically lipids. So the first question is, why do we focus on lipids? Because it's important, because we know that high cholesterol causes a big cardiovascular disease burden, and we know that if we improve cholesterol management, we will reduce the cardiovascular risk. So the number that I quote is, for every 1 millimole reduction in LDL will reduce cardiovascular events by about 25%. So quite a big improvement if we can get that cholesterol down. And we know that patients with cardiovascular disease have other risk factors, often have blood pressure, diabetes, and smoking, and the combined cardiovascular risk is great. And therefore, actually, what we're trying to move towards is this approach where we're dealing with all the risk factors for the cardiovascular disease. And the last thing is thinking about FH, familial hypercholesterolemia. This is a condition which puts patients at high risk of cardiovascular disease. It's a genetic condition, and these patients will have heart attacks or strokes aged less than 50, so quite young. We've got very good treatment to try and prevent this. So this is another low-hanging fruit that we can try and identify and manage. Next slide. So this is the basis behind our framework. We have searches available on your local EMIS or System 1 systems. And what we try and do is identify patients depending on whether they are a high, medium, or low risk. Looking specifically at secondary prevention, we're talking about patients who've got a code with known cardiovascular disease. So that includes ischemic heart disease, peripheral vascular disease, or stroke. The first priority groups are patients who are not taking any statin therapy at all. So that's priority 1 group there. The second priority groups are patients taking a suboptimal intensity statin, so not taking the recommended atorvastatin or rosuvastatin, maybe on a simvastatin or something like that. And then the second priority are patients who are not taking the correct dose of the statin. The third group, and this is what we recommend for routine phase follow-up, patients taking the correct treatment but not achieving the target cholesterol levels. And we'll expand on that a little bit more when we do our case studies. So once we've identified the patients, we would recommend that one of your trained staff, so healthcare assistants or someone, gets in touch with these patients and gets the up-to-date information. So when a clinician sees them, that second contact is useful, and you hopefully get as much information back from them as possible. So get up-to-date information, blood pressure, weight, smoking. Use this opportunity to try and encourage behavior change and self-management. So education about cholesterol risk, about the wider cardiovascular risk of measuring their blood pressure, and signposting to resources that they may need. And we've got protocols to help direct the healthcare assistants for this. The prescribing clinician will then get in touch with his patients, review their cardiovascular risk factors, and then initiate and optimize any therapy that they need. And we've also got some slides on this, and I'll show you on how to titrate the treatment. We also would recommend that you would reinforce the behavior changes and the self-management again at this contact. And we have some resources on intolerances and questions that clinicians might have on how to manage patients who are not tolerating statins. Next slide. So that was secondary prevention, a very similar approach to primary prevention. So the first priority group for primary prevention are patients who have not got a code for cardiovascular disease and then have a calculated Q-risk score of more than 20%. That's our first priority group. The other groups are patients who've got type 1 diabetes not taking a statin or known CKD and not taking a statin, because these patients, again, should be recommended by NICE just to consider a statin. Second priority group are patients with a Q-risk which is between 15 and 19, and then moving to above 10 to 14 in the third priority group. The last priority group are patients who take a statin for primary prevention, but it's not a high-intensity statin. I know I've got a lot of patients who take simvastatin 20, for example. So NICE is recommending moving away from that. And these patients, because they're on some treatment, we've said we can phase them in later on once you've dealt with that big bulk of the first priority group patients. Again, a very similar approach. So using a healthcare assistant or appropriately trained staff to make sure you've got your information gathered as much as possible, an up-to-date Q-risk score is calculated, and then also behavior change and self-management signposts to make sure the patients get a holistic management in terms of the cholesterol. And a similar approach from the prescribing clinician as well. So reviewing the Q-risk score, titrating therapy, and optimizing the other cardiovascular risk factors, which we would always recommend you do. Okay, next slide. So I'm briefly just going to touch on what we have as part of our slide pack, and then we'll move on to case studies, and then we can come on to these if there's any questions afterwards. So as part of developing this frameworks, we've included optimization pathways for secondary prevention. So how do you titrate therapy up if you're not achieving your target cholesterol levels? Same for primary prevention as well. And then what do you do if patients don't tolerate a statin, if they get muscle symptoms or abnormal liver function tests? So we've got a little flowchart to work through on that as well. And then finally, we have some resources on shared decision making. So how do you explain risks to patients? How do you discuss risks with patients? And then, as we said, we've got some FH, familial hypercholesterolemia case finding and questionnaire as well as part of our slide pack. But we thought just to make this a little bit more granular, we were going to go into case studies. I'm going to hand over to Helen now to run through the case studies.
Thanks, Deep. So my name's Helen Williams. I'm a consultant pharmacist and working with the UCLP on the proactive care frameworks. And we really wanted to make this as interactive as possible. So please do download the Mentimeter app. You can see the name of it in the corner of the screen. And the code is in the chat box, but when we get to the elements of interaction, it will also have the code at the top of the slides. So we wanted to take you through a couple of cases as examples of how you might use the framework to manage these patients and to tackle some of the clinical challenges that might come up. So our first patient is Richard. He has stable angina with a history of having had an angioplasty and a stent a number of years ago. He's not currently treated with a statin and is therefore picked up by the UCLP secondary prevention searches as a priority 1 patient. So we know he's got CVD and he doesn't seem to be on a statin. There isn't a record of any statin in his notes, and you can see there his last recorded lipids, a total cholesterol of 5.4, trigs of 1.9 and a HDL cholesterol of 0.9. So this is where we get into some voting. You need the Mentimeter, either the app on your phone or tablet, or you can access it online. And the code you need is this code 64307622. And then this question will come up on your phone. So the question that I'm asking first, in terms of a statin, Richard should be offered Atorva 80, Atorva 20, Simva 40, Resuva 10, or it doesn't really matter which statin as long as you start one. And I can see that a couple of people have managed to vote, so that means the system is working. And we'll see how many people manage to get a vote in. We'll wait for a few few seconds. We won't wait for too long because we're quite tight on time for this meeting. So do vote as quickly as possible. I can't tell who's voting. It's all anonymous, so nobody will come back and go, you answered it wrong. In fact, in many cases, there might not be a right or a wrong answer. But it's really just to see what people's views are, and then we'll look and see what the guidance says to see if we've all got the same view. So a few more seconds, and then we will have a look at the results. So let's see what we have. So half of you have said atorvastatin 80, 25% have said atorva 20, just popped up a bit. A few for Simva 40, and some saying it doesn't matter which statin as long as you start one. So we will go on to a bit more detail on what NICE recommends in a minute, but I think I've got another question before we go into that detail. But the guidance would recommend that anyone with cardiovascular disease gets atorva 80 milligram daily. So that's whether they've had an acute coronary syndrome, whether they've got stable angina, whether they've had a stroke. That is the starting point for statin therapy. But we'll go into more detail on that in a minute. So, there you go, it's the next slide. So second prevention, which includes ACS, atorvastatin 80 milligram as the initial therapy. The reason why this is a good strategy is, one, because it's the evidence base, but a lot of people say, well, I'll start low and go up. If you start low and go up, you can guarantee you've got to do a dose titration in 100% of patients. If you start high and go down, if people have tolerability issues, the tolerability issues are lower than we imagine, and therefore you don't actually have to intervene on 100% of the patients. You might only need to intervene on 20 or 25% of the patients. There are obviously specific patients where you would use a lower dose first line. So if they've got drug interactions, if they've had lots of adverse effects with other drugs, you might be more cautious, and if the patient doesn't want the higher dose. But start with a higher dose and go down if there's problems, rather than very low doses and taking a long time to get to treatment and lots of repeat visits for the patient, which obviously increases your workload. So we don't delay treatment to manage other risk factors, and we don't delay treatment if the patient's had an acute coronary syndrome. Ideally, they should have had a lipid profile done on admission, but if that hasn't happened, you don't wait, because it takes, after an acute event, the cholesterol goes down naturally for about 3 months, so there's no point in repeating it during that 3-month period. You'll get a false reading. So in terms of overall ability, this is your next question, to lower cholesterol, which is the most potent statin if you think about across the full dose range? Is it fluvastatin, simvastatin, rosuvastatin, atorvastatin, or pravastatin? Interested to see what people's views on this are. So the numbers of voters are going up. We've got quite a few voting this time. Excellent.
Helen, just while we're waiting for votes to come in, there are a few questions that are going on.
Oh yes, I can't see them in the box, so do chip in.
Okay, so what we'll do is we'll perhaps go through your case studies first and then take those questions at the end of your section. Is that all right?
That sounds like a good idea, because we might well cover the issues that they're raising.
Thank you.
As we go along. Right, so let's have a look at the results. So pretty split between rosuvastatin with slightly more votes versus atorvastatin. And I think this is partly due to clever marketing, because actually atorvastatin is the most potent within the dose range, with a 55% drop in LDL cholesterol, compared to rosuva, which at the 40 milligram dose gives a 53% drop. Remembering, of course, though, that rosuvastatin is licensed. Well, the license suggests that 40 milligram patients on 40 milligrams should be specialist supervision. So in primary care, we're really looking at sort of 48% being the maximum standard dose drop we would see with rosuvastatin at the 20 milligram dose. So NICE highlights. This is NICE guidance showing you which of the statins give what they recommend, which is a 40% drop in LDL as a high intensity statin, and we're really talking Atorva 20 to 80 and Rezuva at doses above 10 milligram. All the other drugs, apart from Simva 80, don't deliver that level of cholesterol reduction. And although Simva 80 does, we don't tend to use it because of safety issues with the 80 milligram dose. So if we get Richard on a statin, and we haven't really had a conversation with him about it yet, but if we did, what treatment target would we have for Richard? Would we aim for cholesterols of 5 and 3, or 4 and 2, or a 40% reduction in non-HDL cholesterol, or would you aim for something else for Richard? So you're whizzing ahead with the voting now. Really speedy. Excellent. Let's see what we've got now. I can get the results up. So again, a bit of a split. Some on the 5 and 3, and people may remember that that was quite a common indicator in QOF. We had a lot of talk about 4 and 2 when the 2008 NICE guidance were being looked at. But the NICE guidance currently recommends this, a 40% reduction in non-HDL cholesterol, which is a bit tricky to do in practice because you absolutely need the baseline. So that the challenge is knowing what the non-HDL cholesterol before the statin was started, which could have been in a hospital setting, for example, and it does make life a little bit difficult. So we have various targets. Now I say this 40% reduction in non-HDL cholesterol. The Joint British Societies suggested that a non-HDL cholesterol of less than 2.5 would be a good surrogate for us because it's similar to the LDL cholesterol of 2. And in America, they actually don't have any treatment targets at all. They just recommend moderate or high intensity statins depending on the indication. So NICE recommends a high intensity statin. It recommends a 40% reduction in non-HDL cholesterol, which is the ideal. But they have, in the most recent pathway, endorsed a strategy that if you don't have a baseline non-HDL cholesterol and therefore can't work out what the reduction is, you could consider the JBS target, which is a non-HDL cholesterol less than 2.5. So this is the main target, but this is a surrogate if you haven't got the baseline. And just a reminder as well that non-HDL cholesterol is easy to calculate. It's the total cholesterol minus the HDL. So if your total cholesterol is 6 and your HDL is 1, you've got a non-HDL cholesterol of 5. So if your labs aren't reporting it, it is easy to calculate. So this is our optimisation pathway for secondary care. And it really maps what our search is, our priority group. So first of all, is the patient on a high dose of a high intensity statin for secondary prevention? And that would be Atorva 80 or Rezuva 20, as far as we're concerned. If they are, and they're achieving the target, then you just need to review them annually. If they're not, the first step is to get them on that level of statin, high dose, high intensity, and to reinforce all the lifestyle and dietary measures for lowering cholesterol. Then to recheck 3 months later, are they at target? Again, if they're not, make sure they're taking the statin. Adherence is a big issue. And again, look at the lifestyle measures. You might want to think about adding ezetimibe 10 milligram at that point. And again, revisit in 3 months. If they aren't achieving LDL cholesterols of less than 4, or in some cases, if they've got recurrent cardiac events, LDL levels of less than 3.5, they would fit the criteria for use of these injectable drugs, PCSK9 inhibitors, which we'll hear a little bit more about later on, but that's secondary care intervention. So you'd need to think about referring. Hopefully, at some point down this path, the patient does get to the target we're looking for, and you can just put them then onto annual review. Really important, obviously, that we keep an eye on their adherence long term. And this is all, as I said, in line with NICE guidance and the most recent iteration of the NHS England lipid management pathway. So what might happen with Richard, as example, is the HCA gets in touch with Richard to do the information gathering, blood results, blood pressure, weight, smoking status, self-management, educate him on cholesterol and cardiovascular risk. and a bit about behaviour change. So signposting him to resources around smoking, if that's relevant, weight, diet, exercise, or alcohol, tailored obviously to him. In that conversation, Richard, who's just changed his name to Robert, explains that he did try a statin after he had his percutaneous coronary intervention, his angioplasty with stent, and he didn't get on with it because he got muscle pains. So clearly, he's had an issue with a statin in the past. The HCA refers the patient on to a prescribing clinician, and the next step would be to arrange a remote consultation with Richard to discuss the fact he's had a statin and that he has had some muscle pains. So in a minute, Deep's going to come in to talk about how you would approach that discussion. I'm going to ask you one more question first, just to put this in context. So in your experience, what percentage of patients complain of muscle pain on statins? This is a very common scenario in primary care, so I'm sure all of you have an idea about the sorts of figures we're talking about. And great, you're so quick at voting. Speedily in the Midlands compared to some of the places I do these talks. So let's see what we've got. We've got some at 3 and 15%, the majority at 34%, 67% we've got 3 of you, and 0 for 87%. So I'm going to show you my favourite piece of statin research on the next slide. So in this study, they compared to people on statins and people who were not on statins. And in the statin cohort, 87% of people complained of muscle pain. But in the matched non-statin cohort, 85% of people complained of muscle pain. And most of the muscle pain that people experience is not really statin related. It's related to aging while on a statin, I believe. Just another example, there's some very recent data. They did some trials of patients who'd previously reported statin intolerance. So they were using the patients as their own control, basically, and they cycled them through periods when they were on statin and periods when they were on placebo. And the symptoms that they complained about, the muscle symptoms, were just as common when they were on placebo as when they were on the active statins. So I think really important that we really investigate the muscle pain and see if we can identify a link with statin use, because it's very easy when you read the information sheet as a patient to think everything in there is going to happen to me, and any muscle pain I ever get now must be due to the statin. So I'm going to hand over to Deep, who really worked on these statin intolerance pathways, to talk you through how to manage muscle symptoms and how to manage LFT dyscrasias.
Thanks, Helen. So I think the first thing we want to have a discussion about with Richard or Robert is how are we going to approach that discussion with him in terms of his having muscle pains with the statin. The first thing to think about with using our approach is that you will get some information from your healthcare assistants about what their worries are and what they're concerned about, and I think that's really useful, because when you can have that conversation slightly more prepared than we used to do in the past. And we also try to use that opportunity to try and get some information to them. But in our packs, we have some decision-making guides and some information you can give to patients to start having a think about their statins. And I really like the statistics that Helen displayed about the muscle pain, because that really brings to life about the misconceptions that patients have with statins specifically, but also with clinicians as well. So it's just something to think about. Specifically regarding muscle symptoms, the thing that we're worried about is really rhabdomyolysis with statins. So we've developed this pathway to try and find out patients who are high risk. So the first step is that box on the right there. These are trying to find out any other causes of muscle pain. And what you want to find out is if there is any recent infection, recent trauma, drug, alcohol addiction, because they can all cause muscle symptoms. The next step is then to check for creatine kinase, and any patient who's got a very high creatine kinase, so upper limit of normal, ULN is upper limit of normal, so more than 50 times the upper limit of normal, you want to stop the statin and you want to seek some urgent advice, because these patients are at risk of rhabdomyolysis. Moving down then, so patients who've got a raised CK of between 10 and 50 times, you want to check if they've had impact on the renal function. And if they have had some, then they would move on. And again, you would want to discuss that with a specialist. If the renal function is stable, you want to stop the statin and then recheck their renal function and then their CK within 2 weeks. Okay. A similar approach, if they've had a CK between 4 and 10, you can continue the statin and so stop the statin again and recheck the blood test after about 4 to 6 weeks. And if they haven't got a real raise in their CK and the symptoms are tolerable, you can discuss with the patient and review them in a couple of weeks or consider a lower dose. If the symptoms haven't improved, you might want to again stop the statin and review the symptoms and recheck the blood tests. The next step we then recommend is starting at a lower dose and then titrating up to try and achieve the higher dose if possible. And if the patient's having recurrent symptoms when you restart the statin, you might want to consider other forms of treatment such as ezetimibe, or if they need second prevention, then this is a patient you might want to discuss with a lipid clinic for PCSK9 inhibitors. But that's a generalized approach to muscle symptoms. I saw a question on where these slide packs are. They're on our website, and we will circulate them after the talk as well. Next slide. The next part is liver function tests, and we get lots of questions about abnormal liver function tests as well with statins. So this is from NICE again. The guidelines say that if you've got any transaminase rise more than 3 times the upper limit of normal, then you've got reasonable grounds to stop the statin and then monitor the liver function tests. And then once normalized, you can restart the statin with a closed eye on the liver function tests. But if the liver function tests haven't gone up by that much, you can continue it and repeat at 1 month. And if it remains low, then you can continue treatment and repeat and keep an eye on the liver function tests. Again, as always, you want to consider other causes of the liver function test being abnormal, such as alcohol, fatty liver disease, and cirrhosis, and then treat those appropriately. I think, again, with these, the first sentence in that red box is quite, for me, was when I was doing this guidelines, it sort of jumped out. And the advice is not to exclude statin therapy for patients who have raised liver transaminase, which are less than 3 times the upper limit of normal, because they will benefit from the statin therapy, and patients with fatty livers are also going to be benefiting from statin therapy as well. Next slide. Helen, you're on mute, Helen.
Sorry about that, everyone. I'll just find my slides again. So we have another case study. This is a 71-year-old Bangladeshi woman called Sabita with type 2 diabetes. Her HbA1c is being managed with metformin. She again is picked up by the UCLP, or in this case, prime prevention searches, as a priority 1 patient, and as she's not currently on a statin. Her cholesterol is 5.4, her LDL is 3.6, and her HDL is 0.8. So first question is, what do you want to do for Sabita? Do you want to offer her a statin? Do you want to offer her a risk assessment using QRIS? Do you want to give her lifestyle advice, a statin and lifestyle advice, or you are not sure? So those are your options. Same code again. So let's see what you have all said. So some want to do risk assessment, and most of you though want to offer a statin and lifestyle advice. And in fact, the NICE guidance for type 2 diabetes is that we should do a QRIS score for these patients and offer a TORV of 20 for those who have a 10% or more risk of developing cardiovascular disease. So it is different from the previous iteration where we automatically treated type 2 diabetes if they had other risk factors. Now we're encouraged to do the QRIS score. Now, when you do Sabita's, there's no doubt she's going to need a statin. She's at nearly 38% risk. A 71-year-old Bangladeshi female is going to be high risk at that age. The reason for doing the scoring is because in the old system where you were just looking for risk factors, it did miss some patients who are at risk, particularly at younger ages. So this way we ensure that we are, one, quantifying the risk for the patient. A 38% risk of a heart attack or stroke is quite a compelling reason to want to be treated. And also so that we don't miss patients by just focusing on the diabetes diagnosis and other risk factors, particularly those of younger ages. So for Sabita, NICE would say lifestyle issues first, and then recalculate the Q risk score. And if it remains above 10%, then you should offer a statin. But looking at Sabita with a 38% Q risk score, it's highly unlikely she's going to get below 10%. So you want to start that statin pretty quickly. Obviously, we also need to look at rigorous control of blood pressure and retaining control of her blood sugar. Now, there's a question there about would your management change if she had CKD? I'm not going to get you to vote on it because we're running out of time. But just a reminder that we do Q risk for prime prevention patients up until the age of 84, except type 1 diabetics, patients with CKD stage 3 or more, those with FH, or those with pre-existing cardiovascular disease, because that obviously wouldn't be prime prevention in that setting. So when you contact Sabita, you want to offer a statin for her high cardiovascular risk. She's not keen because she's heard from family members that they can cause side effects. So now we're talking about, well, I call this statin hesitancy, a bit like vaccine hesitancy that we're trying to tackle at the moment. She's not willing to try the statin because of her preconceived ideas. So over to Deep about how you might construct this sort of the issues you might bring up in this conversation.
Thanks, Helen. So I think there's also a question in the chat about this as well. So absolutely, patient choice is very important, and what we want to try and do is give patients information so that they can make a decision with us. And I share this sort of data with patients routinely to try and help them understand the risk and try and hopefully help them the benefits of the therapy that I'm trying to recommend. So looking at 10,000 people taking statins for 5 years. If for every 2 mg reduction in the LDL cholesterol, you will avoid 1,000 cardiovascular events. And that's if they've had, that's with taking the recommended statin, and 500 events avoided if you've got no pre-existing cardiovascular disease. So these are the numbers I try and quote to patients, so to try and just get them to understand the benefits of them taking this. And I also quote the adverse events. So for 10,000 people taking statins for 5 years, you will have 5 events of myopathy, between 5 and 10 hemorrhagic strokes, and then between 50 and 100 cases of diabetes as a result of taking the statin. So these are from the NICE guidance we've taken out. So this hopefully helps explain to the patients the risks and the benefits of taking the statin therapy.
And as you've said, Deep, the challenge is, just making sure I'm not on mute again, the challenge is having that conversation with the patient. We have to let people make their own decisions, and hopefully we can support them by giving them this sort of evidence on which to make that decision. The other thing that I often say to patients is, you know, you're worried about a side effect that might not happen. Why not try it for a month and see? And if it happens, I'm not going to force you to take it for the rest of your life. But if you're one of the 90% where you don't have a problem, you know, you're getting the benefits without those disadvantages. So it is all about, I think, about negotiation with patients as to what they're willing to try too. So we're nearly at the end. I know we need to finish now. Lots of resources for patients that we can signpost them to about self-management of not just their cholesterol, but their broader cardiovascular risk, which we're not going to go through in huge amounts of detail. And again, today we don't have time to go into a lot of detail about familial hypercholesterolemia, but this is the FH pathway that is within the frameworks to take you through how to identify patients who are likely or possible FH patients, what investigations to do, and then when to signpost them on. And that leads me very nicely, I think, with one more slide just to give you our email address in case you want to contact us